Hey guys, so today I'll be taking a detailed class on modified radical mastectomy, like how to do a modified radical mastectomy, steps of the surgery through an elaborative operative video. So as we all know, modified radical mastectomy is a very important surgery in your postgraduate curriculum. You have to, though you may not be able to finish the surgery all by yourself by the end of your residency because axilla is a little meticulous surgery, you definitely need assistance, but still you have to learn all the steps. You should know the relevant anatomy to do the surgery. The steps of the surgery will be asked as a very important viva question during your clinical examination also. And if you know the steps properly, you will be a very good assisting surgeon to your seniors doing it, so that you can learn the surgery well. Okay, so we'll go ahead with the surgery. First, I'll be talking about the positioning of the patient. As like any other surgery, positioning of the patient is very, very important in modified radical mastectomy. So what is the position? The patient should be lying supine on the operating table. Head end of the patient should be at the edge of the table. Head end should be at the edge. That is very, very important. And towards the side of the pathology where you're operating, that arm should be abducted properly at 90 degrees. A slight abduction more than 90 degrees is also fine. And make sure that the arm board does not move at all. I'll be frequently asking my own PGs and my own junior assistants after proper placement of the patient whether the arm board is moving or not. That is very important. If the arm board is not tightened properly, you might think why am I elaborating on this? But if the arm board is not tightened properly, what will happen is the hand will get further abducted. If the hand is getting abducted further, doing the axilla will become very, very difficult. And whether to keep a sandbag or not below the shoulder blades of the patient, usually I am not keeping any sandbag, and I am not finding the surgery any more difficult. Even without the sandbag, if we give a slight head up, the surgery is still easier. I find sometimes when we keep the sandbag, the scapula is a little like this and that, and that's changing anatomy for me. The posterior axillary fold and all is getting oriented differently. So I'm not personally keeping a sandbag. It's a personal choice or according to how it is followed in your role in your own institutions. Okay. So after proper positioning of the patient, you have to ensure that the posterior axillary fold of the patient should be in line with the edge of the table. That is one more important point. So the key points to know during positioning of the patient are that the hand should be abducted at 90 degrees, the armboard should not be moving, head end should be at the edge of the table, the posterior axillary fold should be touching the edge of the table. In this way, the surgeon and all the assistant surgeons can be very comfortable. And what is the position of the surgeon and the assisting surgeons? Surgeon should be standing at towards the operating side of the patient, and the assisting surgeon should be standing at the head end of the patient. The first assistant should be standing at the head end, between the head and the right arm of the patient. Okay, it's, in this particular patient, it is the right side, towards the side where we are operating. They should be standing between the shoulder and the head end of the patient, and the second assistant should be standing on the opposite side of the patient. If assisting is difficult for the second assistant, they can use a footstool to reach the operating field. Okay.